Now we're going to try something a bit different. And over the next 45 minutes or so, I want to give you a flavor for what's coming next. What I think is one of the next big things around out-of-hospital cardiac arrest in Scotland, and that is CAREzones. And I've called this few minutes of introduction that I'm about to give, what are cardiac arrest rescue zones? That's what CAREzones stands for, just in case you were struggling to make the connection after all those sausage rolls. So what are CAREzones? But I actually want to start the conversation a little bit further back than that and say why CAREzones? And then we'll talk about what they are. And then we've got some friends from Dumfries and Galloway and Scottish Ambulance Service and other places who've been putting this into practice, who are going to tell us about that. And then we're going to explain how we need your help. All right, so that's where we're headed over the next 45 minutes. So firstly, why CAREzones? And in order to get into this, I want to introduce you to two models, which you may have seen before, but two mental models that I think are really, really helpful. And this first one is adapted from a chap called Charles Handy. You may be familiar with Charles Handy. He writes books. He's a philosopher. He's really into organizational behavior, business behavior. And he's got this thing called the S-shaped curve. And he, first of all, described this in a book called The Age of Paradox as a way of talking about how businesses perform. And then he liked, like this happens quite often, he liked the idea. And so he brought out a bunch of other books about how this curve is actually the answer to everything. It describes everything, from how businesses perform to human life to the lifespan of an idea, everything. And it's quite a fun idea, so let me talk you through it and then explain how it relates to CAREzones. This curve actually describes performance or impact, or it could be growth over time. And if you look at the curve, you see that when an idea is new and everybody's dead excited about it, it starts off here. And then it maybe has a dip after the honeymoon period as you begin to find your feet. But then it picks up and you get some growth. And if it's a good idea, if it works, then you get a period where things go really well. And over time, performance or impact increase. But then inevitably, as surely as night follows day, with every idea, with every innovation, no matter how good it is, no matter how special it is, that begins to trail off as you reach maturity. And what Charles Handy says is, listen, the best time to think about the next thing, to begin to do something new, is not after you've got to the point where you've passed maturity and you're into drift and despair and death of the idea. It's before you get to that point, while you're still at the top of the crest. And that's when you should think about the next idea, the new start, before the first curve runs out of momentum. Because once the first curve runs out of momentum, nobody wants to know anymore. You've got no money left, you've got no enthusiasm left, you've got no credibility left. But the problem with starting the second curve before you get to the climax, everybody says, well, why are we doing something new? What we're doing now works perfectly well, or it seems to be. We've had all this growth over this last period of time. Why on earth would we start something different when what we've got is working? And my suggestion is that the parallel here is with the existing cardiac arrest strategy, which comes to an end this year. This is the end of the 2021-26 strategy, and CAREzones. What we've done since 2015 and the first strategy has changed the face of cardiac arrest in Scotland. You guys have changed the face of cardiac arrest in Scotland. Bystander CPR is up from 40% to over 60%. Survival has doubled from 180 odd survivors a year when we started to over 360 now. And that's because you've got 3 times the likelihood of having a public access defib used. We've got all sorts of different kinds of secondary response to cardiac arrest with the Scottish Ambulance Service. Things have changed significantly. But I would suggest that we're just heading to the top of the curve. Andy Lockie showed data earlier on today that showed our survival figures going up and just beginning to flatten out after the rebound from COVID. And now is the time to do something different, and CAREzones are that different thing. So mental model number 1, the second curve. It's time to jump into the next curve. Mental model number 2, the Utstein formula for survival. This is a very interesting, totally made up, but interesting mental model. And what it says is this: for survival, you need three things. You need medical science, and that's essentially what's in the guidelines. So we need to know what do the clever people like Wrong and like Andy think we should be doing to get people's hearts restarted. But then you need educational efficiency. You need to get that guidance and communicate it to people like us who are involved in the front line, involved in the community, involved in the emergency departments, implementing those guidelines. But then you need local implementation. So it's okay having the thing to do and knowing what to do, but you've actually got to have a system that allows you to do it effectively, the right time for the right patients in the right place. And these things multiply. So let's say the medical science is really good. Maybe not 100%, but maybe it's 80%. And maybe the educational efficiency is pretty good. Maybe it's 60%. But then you've still got 60% of 80% by the time you get here. And then maybe local implementation is a bit patchy, and maybe you've only got 20%. So now you've got an even smaller fraction of your guidelines getting through to the end of the process. So we need something new, we need a second curve, and we need to fix the problem of local implementation. We know what to do, it's been established, we all understand what that needs to be, we've been educated, but how do we locally implement what needs to be done for cardiac arrest? And that's the CAREzone approach. So CAREzones look more complicated from this diagram than they really are, but really it's about taking an area of Scotland, let's say a council area. We understand what improves survival after cardiac arrest, but how does that work in any given area? So we select a council area, and in the example we're going to talk about this afternoon, it's Dumfries and Galloway. And we went and we had a chat with folk from the council, and it took us a couple of goes. We had a couple of false starts. We weren't very good at explaining the problem initially, but eventually we helped them understand what was required to improve survival after cardiac arrest. You need to identify the arrest. You need to do bystander CPR. You need to have defibrillation. And in order to get that, you need to teach CPR in schools. You need to do it in the community. You need public access defibrillators. You need community responders. You need good sound. And once we'd articulated that, we then found out what was already going on in the area in Dumfries and Galloway. There were already organizations that were doing some great work, so let's help them. Let's find out what the people living there really want to do. How's it going to work in your environment? What this looks like in Dumfries and Galloway is going to be very different to what it looks like in Greater Glasgow, for example. And then we build a plan. Get the Coalition of the Willing, Assembly of Avengers, Fellowship of the Ring, whatever your favorite metaphor is, and we make a plan. And we use the data that we collect as a service and as a research group to implement and evaluate how that plan is working. And the data looks like this. We've got information about cardiac arrest risk. We know where the cardiac arrests are happening. We know how long it takes to get an ambulance to a cardiac arrest, virtually anywhere in Scotland. We know about CPR rates and where pads are being used and where they're not being used, where there are good sound volunteers, where familiarization is happening in schools, and where there are community responder schemes around Scotland. And so we put all of that data together and use that to inform the plan. And clever people within the ambulance service, like young Donald MacPhail, will be able to construct these kind of maps. And this is done for those of you unfamiliar with the shape of Dumfries and Galloway, that's what it looks like on a map. And there are two examples of the data that we've been discussing. One is response times. And then you can see the shortest and longest response times to different areas. And this is pad use, public access defib use. Where are the areas where we need more defibs? But it's not just maps and small numbers, because that's great if you're really immersed in this, but what if you're not immersed in out-of-hospital cardiac arrest? What if you're not used to looking at maps and response times? How do we make some of this information more accessible? And actually, how do we make it accessible to everybody? Our aspiration is that councils and people interested in cardiac arrest provision in their area wouldn't have to come to the ambulance service and ask. They wouldn't have to read a special report or have special permissions, but the information will be available freely to everyone who's interested. to start conversations and help people build better systems. So what I'm going to show you next are just 2 more slides that are not a finished product, they're not prime time, but they're a glimpse of what might be possible in the future. This is what happens if you try and stack up cardiac arrest risk, so number of cardiac arrests per 100,000 of the population on this axis, along with deprivation along the x-axis, so percentage of the population in SIMD1, poorest 20% of the population. Each one of these circles is a council area. Size of the circle is the population. You can see some are little tiny island ones, some are much bigger. Glasgow City, so not GG&C, but Glasgow City, Edinburgh City. But it's interesting when you do that because you see little outliers appear. Poor old Inverclyde. Inverclyde that has almost 40% of its population in SIMD1, one of the most deprived parts of Scotland, and has the highest rate of out-of-hospital cardiac arrest anywhere in the country. And this kind of data really could be used to inform planning. Where do we start with CAREzones? What do we say when we go to Inverclyde Council and say, we need to help you make a plan to improve survival after out-of-hospital cardiac arrest in your area? Here's one more map. This is a slightly busy one. I put this in here partly to respond to a comment that Steve Brooks and I had in discussion yesterday. When you get to a council area and try to explain what do you need, you've said 5 things here. You've said school training and community training and PADS and Good Sam and responder groups, but what do we need and where do we need it? Well, the data can sometimes help us there as well. So this is Dumfries and Galloway. These are the wards, so the sub-council areas, if you like, and they're all very different. Some are very remote and rural, some have larger populations. And if you take all the data around cardiac arrest rates, response times, where the pads are, all that kind of stuff, and you put it through the mathematical sausage maker, you can generate this kind of dashboard. So here, what we've done for each of the wards is we've said, well, look, let's add up how likely it is that the population are living close enough together that pads on the wall will be a good idea, and we'll make a pad score. And then let's factor in how long it takes an ambulance to arrive on average, and how far apart the population is in other parts of the council, and let's make a responder score. And then we can have a recommendation, mathematically, which you can use to help inform the planning. So for each of the wards in Dumfries and Galloway, here's a recommendation. In Abbey, we should have responders, whereas in Lochar, we should have pads on the wall. And there are other places where we should probably have both. And this is response time in minutes, the median, and that's the, can't remember what that is. But you see, providing this data is not telling people what to do. It's not prescriptive. It's not computer says this, therefore you should do it. But it's giving people the tools, giving council members the tools, giving schools the tools, giving people who live locally in communities the tools to understand the shape and size and scale of the problem in their area, and to work out which of the many things they could do will be the most appropriate implementation for their context. There are many things you could do. Not all of them will work equally well in all geographies. So finding which is the one we should reach out for is part of the CAREzone project, making implementation work locally for the people of a given area. So what I'd like to do then is invite some guests from Dumfries and Galloway, some of the team involved in CAREzones, to come and join me on the stage. When each one comes up, I'm going to let them introduce themselves, just to say who they are, because then I don't have to remember everybody's Sunday titles. And I'm going to ask them one question about what they've done. After we've gone through that, we'll then have a little bit of Q&A at the end. So as you're listening to what people say, if questions are bubbling up in your mind, hold on to them, and then get ready to ask them at the end. Does that all make sense? Seeing a few nods. I don't know if that's just people falling asleep or whether it's... Excellent, great. So, Gillian and Barry, would you mind joining me up on the stage? Let's have a big hand for Gillian and Barry. It's one mic, so you'll have to share. Thank you both for joining us. Barry, do you want to tell us who you are?
Hi, everybody. I'm Barry Watson. I am the transformation lead working out of clinical services in the ambulance service, and I help to manage the project of implementing the CAREzone pilot in Dumfries and Galloway.
Great to have you with us, Barry. And Gillian, do you want to tell us who you are?
Good afternoon, thank you. I'm Gillian Bryson. I'm Executive Director for Education, Skills and Community Wellbeing for Dumfries and Galloway Council. So I'm responsible for our schools and our community and a wide range of services within our council. So it's a great pleasure to be here.
So Gillian, just hang on to the mic there, and I want to ask you both just one question. We could talk all afternoon because there's lots to cover, but just to give a flavour. Gillian, when we came with this idea and tried to communicate to you, cardiac arrest is a public health problem in Scotland, and we need your help to fix it. What was your understanding initially, and what was the kind of journey you went on in trying to understand what on earth we were trying to say?
Thanks very much. Councils, as you might know, are quite specific in terms of delegations and committees, and there are very specific rules and regulations. I'm sure they work similarly to your silos within NHS. So when this came to me, Chief Executive's Office gave it to me because it had health in the title, and I thought, why is this my job? Surely our NHS colleagues are going to be frustrated that I'm, as in charge of schools, that I'm getting involved in this. I don't want to step on people's toes. I don't want to interfere. This is not my area of expertise. And the couple of false starts that you referred to, couldn't see what this is. So why am I the person that's best placed to do this? And then the penny dropped, and it was one of our Scottish Ambulance Service colleagues who basically said, it's a public health problem. It's a health problem when they get to the hospital, but we've got to be alive by the time we actually get them in the ambulance. And it just made me realise that I did know a lot about CPR. I know a huge amount of CPR, but my CPR is about community participation and resilience. It's a different kind of CPR to what you're good at. It's all about connections and permissions and reality. So I work in a different world, but joining my CPR with your CPR, I think, is where we started to understand. And Gareth told me the story about the double-decker bus, and that was one of those, just make it real for people. There's a double-decker bus of people who have an out-of-hospital cardiac arrest every week, and only 4 out of 10 of them survive. And all of a sudden, it made sense that I can do something, because I understand our communities, I understand our resilience, and I understand how to communicate that message. But you're the experts, but I can help you.
Julie, I love that community partnership and resilience. I'm going to steal that from you, Barry. So it's a brilliant realization. That's what happens when you get medics to try and explain things that aren't medical. You know, it gets misconstrued. But cardiac arrest isn't a hospital problem. It's a community problem. And Barry, we were trying this for the first time. We hadn't done it before. We were making up as we go along. What were the challenges in terms of getting the apparatus, the process together to make CAREzones work, to get the right people in the room and so on? What were the initial challenges?
Well, I suppose the whole thing, we always say that CAREzones is like a hyper-local approach. It realizes that every council area, every community has its own distinct characteristics. It's about sort of tailoring a solution designed to complement those unique characteristics. So I suppose when you go into a place like Dumfries and Galloway and you're going in cold, you want to be open to getting help from all sorts of different people. But by the same token, you don't necessarily want to go in and have like a town hall meeting where you're getting everybody to put their hands up, because that'll just be unmanageable. So I suppose it's the challenges was trying to identify sort of a small stakeholder group in the first instance, local leaders and decision makers who had sort of the authority to make decisions, take actions, and the reach to link us in incrementally with other people that can help, rather than getting everybody involved straight away. So we were really, we're really lucky in Dumfries and Galloway to meet up with Gillian and her team. We had great help from DH9, who were mentioned earlier in the event, and we had great buy-in from our Scottish Ambulance Service local subdivision as well, and they all helped us formulate a pretty tight plan, and then expand that plan and get more and more stakeholders involved as we went along.
Brilliant, brilliant. Thanks, Barry. If you two wouldn't mind just grabbing a seat in the front row, I'm going to grab you later for a bit of Q&A, and if Roger and Susie want to come up and join me. Really helpful. So this group of stakeholders was assembled, and Barry boiled down what needed to happen into 5 levers. And those levers, if you like, those things that if you do these things in some degree, in some way in your context will result in greater survival, were training in schools, training in communities, public access DFibs, Good SAM, and community cardiac responders. And Roger and Susie, you've both been involved in 2 of those levers in Dumfries and Galloway. Do you want to introduce yourselves first of all?
Hi, I'm Susan Gardner. I work for Save a Life for Scotland, very closely with Gareth and Dominica.
Hi, my name's Roger Hill. I chair the DH9 Foundation, which is a small local charity which has only been in existence for 18 months.
So, Roger, hold on to the mic there. You're involved in lots of things. We've heard a little bit during the Newton Awards, actually, about just how much you guys have achieved in a very short period of time. But focusing in particularly on community training and community familiarization, can you talk about maybe one of the ways in which things that are particular to Dumfries and Galloway, where you were able to work in your favor in terms of reaching large numbers of people in the community?
Yeah, so I used to work in education, in senior position education in different education authorities, and worked in Dumfries and Galloway prior to retiral. So therefore we had a link in there into the schools, and that we've now visited and been part of training in schools, free voluntary training across nearly half of the schools in Dumfries and Galloway in that 18 months. But we've also reached out to, there's a huge youth festival called Youth Beats, which has 20,000 participants each day over 2 days, 40,000. And we were invited to be the health partner of that last year, and we're going to be a health partner of that this year again, marquee, and we'll be doing CPR training all day throughout both days. So there is a link into that. And just to pick up something Andy said earlier this morning about CPR being compulsory in Scottish schools, and it's not. The policy intention is that CPR training is compulsory, but it's not actually, and it takes the goodwill of individuals to actually make that happen within the schools.
Yeah, so top down is there, but bottom up needs a bit of work.
Absolutely, we need to bring everybody on board.
And so that's a great illustration of how implementation in Dumfries and Galloway looks different, because they happen to have a rock festival of 20,000 people a day coming through the doors. So that's a place an opportunity can be taken. But that's not going to be the same in every council. Susie, do you want to tell us, your work in Save a Life for Scotland has been focused on many things, but one of them is Restart Our Heart Live and what happens in schools. Dumfries and Galloway have done some interesting things, or beginning to do some interesting things around schools engagement. Do you want to outline what's been going on?
Yes, so the council were amazing. I worked with Lindsay Green, who was dealing with the schools and well-being. So Lindsay put together a very thorough information bulletin for the schools, and that included, well, the question was asked, has your school had CPR training? When did you last have CPR training? Would you want CPR training? And it gave them all the information that they required to move that forward if they wanted any CPR training. She also, we were on the run-up to Restart a Heart Live, so she sent out a lot of information about how to engage with Restart a Heart Live, and it certainly worked, because they were the second top council in Scotland. They'd 33 of their schools engaged on the day, so that was absolutely amazing. But on the back of that, what they then did was their fantastic technical people then got involved, and they mapped all the schools so we could actually see, looking at the Dumfries and Galloway map, all the schools on it, when they've had CPR training. Was it in the last year, last 2 years? Did they engage in Restart a Heart Live? And that's just a way to open up conversations. It wasn't to shame anyone that wasn't doing it, but, you know, more to open up that conversation. They can see, oh, how do we, you know, get involved in this? So that's now public facing, which is great.
Brilliant, thank you both. Grab a seat, and can I invite Donald and Paige to come and join me? So we've talked a bit about schools, we've talked a bit about communities, a bit about the brilliant effect of having a local champion that catapulted Dumfries and Galloway to the top of the charts of engagement with Restart a Heart Live. And now we're going to talk a little bit about Good Sam and about cardiac responder schemes. So would the two of you like to, not that you need any introduction as to what organisation you work for, but do you want to just say who you are?
Donald McPhails. I'm the clinical effectiveness lead for out-of-hospital cardiac arrest within SAS, and looking after Good Sam, or the response element, at least anyway, of Good Sam is under my remit.
And I am Paige Fletcher. I am the cardiac responder development lead for the Scottish Ambulance Service, and it's my role to look after all of the community cardiac responders, volunteers.
So again, just hang on to that for a sec, Paige. So community cardiac responders. I wish we had more time to talk about them, but actually, Dumfries and Galloway have embraced this. Very rural council embraced this, and it's worked out quite impressively to start with. Do you want to just fill us in on what's been going on?
Yeah, so just to avoid any confusion, the community cardiac responders, it's essentially Wildcat on the move. So we know that it's been a great success in the Grampian area, and we know that it in some areas can improve the response times by up to 5 minutes, getting somebody on scene with a defibrillator and starting CPR prior to the ambulance crew arrival. So as part of the CAREzone project, we're looking to introduce cardiac responders across Dumfries and Galloway. October last year, I had the honour of going down, meeting with a lot of the council, and that's where this collaboration is working really well, because we're all working together. But we had 10 people sign up, and there's now 10 responders currently in the Glen Kens area, and they've attended a number of calls since October last year, and we have already actually had a success story and a really good outcome, a discharge from hospital following one of our cardiac responders being first on scene.
Brilliant, brilliant, thank you. That's, and it made the papers. Responders switched on, Good Sam, first shift, and within a couple of hours had a call and defibrillated someone successfully, so terrific. Couldn't have asked for better PR, really. Well done. And Donald, Good Sam is something we want to propagate, and we've heard a little bit about this already, started doing across Scotland. When it comes to getting a council to encourage folk to engage with Good Sam, what kind of approach are you taking?
So I've got access to all the data that we get from Good Sam regarding the number of people who are in any given area and who are being alerted and attending. And also then the types of person they are, as in when you sign up, you would say you're a first aider or a member of the community or firefighter or whatever you might be. So I can take that data and then incorporate into maps of a particular local authority, so in this case, Dumfries and Galloway, and then just use that to be able to just identify areas of particular need. I suppose in general, we need more Good Sam responders across the country, wherever you are. But in some areas, it probably makes more sense to focus efforts from a council point of view. So then, speaking with Gillian and her colleagues, once you're able to identify sort of particular areas within a local authority, we can then tap into their knowledge of the groups that currently exist, where they might be able to have some input and impact to just help that promotion piece and be able to just describe to people within these particular groups what Good Sam is, the benefits of it, and just encourage them to sign up. It's not just someone from the ambulance service coming along saying, just come and sign this, it'll be great, but it's also their own council people saying, it's our community, you're out there doing work already voluntarily to help in your community, and this is something additional that you can do to assist.
Brilliant. Thanks, Donald. Thanks, Paige. Do you want to grab a seat? And Michael and Martin, do you want to come and join me? So really helpful there to hear about using what's already there in terms of responders, in terms of resources, people who might be able to sign up to Good Sam, and fantastic affirmation from Paige there about what happens when you pair the right solution to the right kind of geography with cardiac responders. So, Martin and Michael, thank you. Do you want to just tell us who you are?
Yeah, good afternoon. I'm Martin Ogilvie. My job in the council is the Resilience and Community Safety Manager, but I also chair the local resilience partnership.
Great.
And I'm Michael Hamjans. I am the head of ambulance services in Dumfries and Galloway, and I'm now chairing the tactical oversight group for the care zone in D&G.
Brilliant. Hold on to that microphone there, Michael. So, part of the thinking around care zones is not just how do we start something up, how do we get people into a room, but how do we make it sustainable? How do we make it continue to develop? How do we make this into business as usual, something that will continue and not just be an enthusiasm which is here today and gone tomorrow? And these gentlemen are part of the mechanism that we're putting in place to do that. Michael, do you want to tell us about the Tactical Oversight Group, as you call it, which is a fantastic title for any kind of meeting? What is it and what does it do?
Yeah, so we basically took the care zone concept and formalized it into a tactical oversight group. And with the help of Martin and Gillian, aligned it to the Safer Community Partnership. Safer Community Partnership. And we've now got our own terms of references outlining our intent. We've got and membership as well, so we now confirmed who needs to be in this group. We set our objectives aligned to the care zone levers. We developed a communication plan as well, and an action plan to how we achieve those objectives. And we are reporting, as I said, to the Safer Community Partnership. So it's our intention to report. So we only started this January, and after 12 months or annually, we're going to report into this partnership, and hopefully to either get praise and encouragement to continue, or get some recommendation for improvement. So we basically have somebody to check our homework and continue progressing our objectives, I suppose.
Thanks, Michael. And can I just say, it's not a given that Scottish Ambulance Service would run that group, and thank you so much for putting your hand up to say you're willing to chair that tactical oversight group and be part of pushing this forward, which is terrific. And I just wanted to ask Martin, from your perspective, from within the council infrastructure, if you like, how does translating care zones into business as usual work from your point of view?
Yeah, I guess if you think back to that first S-curve, we were aware of projects that have maybe gone into that decline phase and the difficulty of keeping things going. So we had to embed this in a structure that was sustainable long term. So for a couple of years, we've had a Safer Communities Partnership that already does that for other important initiatives like road safety, water safety, antisocial behaviour, and safety at our large, big festivals and events that we have. So we have a structure, we have a partnership. We don't really care what uniform people wear, what headdress people wear, what rank people are. It's about the contacts and their knowledge. The council might chair half the groups, but that doesn't really matter. We've got fire officers coming in, ambulance officers coming in, police officers coming in. In Dumfries and Galloway, we've got a strong and long legacy of partnership working. It's a big area, but a small community, and we all tend to know each other and network well. So it was about drawing on that, building a sustainable and deliverable future that can take this initiative on and stop it going into the decline, and can be the forum for the next part of the S and the next part of the S, so we can keep on going from strength to strength. Brilliant.
Thank you very much. Gentlemen, do you want to grab a seat as well? And we'll just we've got a little bit of time for Q&A. I know that's been an absolute whistle-stop tour through CAREzones, but what I hope you've heard is CAREzones are hyper-local. They're, as Barry said, they're about a location. And we're going across Scotland, and one day we're going to get to your location, whichever council you live in, and we'll need your help when we get there. CAREzones are about champions, local champions, like the folk who are helping with training at events or drumming up enthusiasm in schools for Restart a Heart. You could be those local champions in your area. whether you're Scottish Ambulance Service, whether you work for a third sector organisation, Scottish Fire and Rescue, Police Scotland, whatever, whoever you work for. CAREzones are about taking what's there in terms of people, in terms of community wealth, Gillian's called it, and in using that to help save lives after cardiac arrest. So the opportunity is coming for you to be involved in CAREzones, and we want you to be prepared and ready when that opportunity arrives. We've got just 5 or so minutes for any questions. I'm not going to ask all the guys to come and stand at the front here. I'll come down to here. But does anybody have a question for any of the huge brains trust that we've got at the front here who know more about CAREzones than anyone else in the world? Not a lie. Oh, sorry, wrong. Go on.
Thanks. It's fascinating. Thank you very much. Thanks. It's fascinating to hear about this stuff for someone who works exclusively in secondary care. And I'm interested to know and understand what's the measure of success of implementing a program like this? What objectives and what outcomes are the measure of the program?
So yeah, we've as the program's gone on, we've sort of been developing a set of measures that we can measure success by. So it'll include things like the amount of things that are very easy to measure, like the amount of Good Sam sign-ups we have in specific areas, the amount of defibs that are within a certain distance of cardiac arrests, and calls that are answered by our amazing responder schemes. But also there'll be some like longer term measures, things like neurologically intact survival, ROSC, et cetera, that we won't really see in the immediate term, but we'll be looking to measure over the coming years. And that's why CAREzones isn't just like a strategy that you implement and you see the big ticket sort of item straight away. It's really embedding a new way of doing things in the long term so that we get those long-term positive patient outcomes.
Brilliant. Thanks, Barry. Any other questions? We've got one at the back and then at the front. Steve.
It's Steve again. This is going to be the next Scottish idea that I steal for Canada. So I was just wondering, and Gareth and I were speaking about this last night, can you give us any advice of how to get in the door at the council, how to get this on the agenda, and how to get them to believe that it's their problem and not the NHS?
I'll stand up. It's a hearts and minds issue. Tell stories. Tell stories and don't tell them that they have to do it. Ask people to help you with the problems that you've got. When Gareth indicated that only 1 or 2 or 3 people in my community survive an out-of-hospital cardiac arrest, and we could almost track that through the data, and I could see it on the map, and I knew people that I worked with that had been affected by this, I wanted to be involved. I knew I had skills and I knew I had fabulous people that I could bring on who could help us do this as a community. So it didn't become a delegation. It didn't become a task or a part of a strategic plan. It became something that was really important for our communities to take ownership of. And I've said before, and I'll say that it's been the best thing I've been involved with all year. I've been in Dumfries and Galloway for 23 years. And to actually work with people, we talk about partnership working and we talk about multi-agency work, but we're really honest with each other, and we've got such a broad range of skills that we could pull together and make a difference at a hyper-local level. So don't tell the councils what they need to do, but ask for their help, because people want to help. They sometimes don't know how to help. And I think your sign here, I think, is really important. Give people permission to help, and they will.
Brilliant. Thanks, Gillian. That's great. Amanda, do you want to add anything to that?
I suppose we just realise that every council is different. We've got an ageing population and a decreasing population, but we've still got 20,000 kids in schools. We've still got 78,000 households. And we need to think about the communications channels to get that right. So it's about a multi-channel sort of marketing campaign that is sustainable. And there's already some great national activity that we can piggyback. So big national events that we can use locally in schools. We can do, the council's got massive reach. We can put a leaflet into eldest and only children's school bags. We can put stuff on our council tax letters. We can put QR codes in all our buildings. We can train all our own staff. 25% of the working population of Dumfries and Galloway are employed somehow or other in the public sector. So how many people can we reach because we can sort of get them trained, get them talking about in the workplace that will go back to the households? I mean, I actually just moved out of Dumfries and Galloway last year to a town called Biggar that many of you will know, about an hour south of here. So in the last week in Biggar, every single shop, pub, restaurant, cafe that I've been to, there's now hundreds of these leaflets that cost a fraction of a penny to do. So it doesn't all need to be in social media and TikTok. It can be leaflets. And when I've asked in the places I've been to, they say that people are really interested. It's starting discussions, they're picking it up. There's all the information you'd expect on the skin, and on the inside there's a nice map of the village with the 7 or 8 defibs that they've currently got deployed. So with a town of 3,000 people, people know where the defibs are within 100, 200 metres off their house. You know, it will cost the council in Dumfries and Galloway pennies to do that for our villages and towns across Dumfries and Galloway. Thanks.
Brilliant, thanks. So some great ideas for engagement from Gillian, and 10 great ideas before breakfast for communication from Martin. That's terrific. Liam, you had a question.
Yeah, thank you. I think this is obviously a fantastic idea, and I'm already got the cogs thinking about how we can spread this UK-wide. I guess my thought is the ultimate thing we want to aim for here is to actually prevent the cardiac arrest in the first place, right? And so what's the next step in terms of bringing in the local health services to actually target those patients who are most at risk of having this cardiac arrest, and possibly even bringing in Ron from the secondary tertiary sector to go, actually, these are the patients that are most likely to come through my door. How do we start then reaching them to try and prevent the cardiac arrest in the first place with, you know, health promotion advice, et cetera, et cetera?
Yeah, that's a huge question. And I guess the logical direction of travel, isn't it, is to go upstream and say, you know, we want to get the community ready to respond before the emergency services arrive. And what you're challenging us to do is to think, well, how do we prevent people from having the arrest in the first place? I think a joined up health service would tackle that. I think it then falls, it's almost a bit the other project that comes before the CAREzones project, if you like. So absolutely needs to be done, but it's probably too big to fit into this remit. Harry.
Yeah, that was a great question. So something that I recently started as a trial we did just 2 weekends ago was a public health checks event. And I got a couple of local doctors involved, 4 paramedics, diabetic nurse, and we went and did a community health check event. It was the first one. I've been planning this for a few months. Normally we go out, we're doing CPR events, health awareness events. So this health check event I've been working on for a month, and so the trial was two weekends ago. We had 80 people come through the door, and we didn't advertise it much because we didn't know, we didn't want it kind of overpopulated with the people coming in. And we had 3 defibrillators, we had doctors here. So with the 80 people that came through the door, 7 people we had to refer to the doctors for conditions they didn't know they had. And 1 person we had to send to A&E at that time, who was quite really ill. So this is exactly what I'm planning to do ahead, as well as CPR events, is go out in the community doing these health check events. And we are in talks now, well, early stages, to try and get external funding for that. I've talked to the doctors, and some of the doctors are friends and family. They said there is funding available that doctors get, GPs get, but they're not using it the right way. So we're going to try and tap in and see if we can get some of that funding diverted to us in the ambulance service, who has got the equipment, but we need the funding to go out and start. Since that event, I've had calls from Edinburgh, Dundee, Aberdeen to come out and do these events, and I was expecting that. So yeah, I think that is a way forward as well, you know, so just to kind of join on with what you're doing at the moment.
Brilliant, Harry, that's terrific. So apologies for my failure of imagination. Harry has presented at least part of the solution, and so that's a great idea of how we could possibly move upstream. That brings us about to time, unless any of you guys have anything. You look like you're bursting to say something, Michael.
No, I just want to say, so very similar to how Jillian felt, is although I'm in the emergency business for 25 years in D&G, I got really excited about this project because there's really some tangible evidence put in that we can make some improvement. It really felt like that. Ultimately, we obviously want to improve the cardiac arrest survival rates. That were not going to be achieved within next year, 2 years, or before we can actually properly measure it. But with us setting these objectives aligned to the levers, we can actually measure it, and our preparedness for responding to cardiac arrest, this is something we can really measure. And it meant, Paige mentioned earlier that last year, towards the end of last year, one of the community responder groups who just really been introduced within the same day of same week, there's a first cardiac arrest positive outcome, the survival rate. And when this was shared within the group, although everybody only has a tiny wee role to play in it, there was really a buzz around this group. We all felt we had some part into the survival. And in that spirit, we want to continue it. And if we can save one more life, then it's worth doing it. But I'm very confident that going forward, we can improve our cardiac arrest survival rates.
Brilliant. Thank you so much. Thank you very much, guys. I mean, ultimately, I think the take-home here is, it doesn't matter how good the plan or the strategy or the buzzwords are, the thing that makes a difference is this, the human capital that you've just seen on display, the enthusiasm, the relationships, the sense of purpose, and the willingness to get involved and try something that we haven't clearly defined, but we're defining as we go, but is making a difference. And thank you so much for that. So thank you guys for being willing to come. And I need serious self-control now. We've got a coffee break, which is, Dominica, how long? Oh, it says on there. Come back by 15:20. So you've got 20 minutes. Please go and see the sponsors, grab a cup of coffee and be back by 15:20. Thank you.